Okay, thanks. Welcome everyone to this session on enhancing data use at subnational level. My name is Johan Sabo. I'm just moderating this session, which is presented by Wilfred Segnoni here from HISP Tanzania, and Marina Marcelino, also HISP Tanzania and University of Oslo. And we also will have perhaps input online from Masoud Mahundi from also UDSM and HISP Tanzania. Short background, this is a session coming out of several abstracts submitted for the research track. And what they all had in common was that they looked at research coming out of activities going on in the District of Excellence initiative in Tanzania, which is a very interesting way to organize a joint collaboration between ministry, local governments, universities, NGOs like HISP Tanzania, to together evaluate, identify challenges, and agree to use the District of Excellence as a place to try out interventions and learn from them, with the aim of scaling up successful interventions countrywide. We are very happy at University of Oslo to be part of this. We have great benefit in learning also from the District of Excellence. We have opportunity to send master students there, which I think is very, very good. The abstracts submitted covered different aspects, but they all looked more or less at the current drive to decentralize use of DHIS all the way down to facilities. So taking this decentralization efforts in Tanzania also into the digital sphere. So today we will hear from the speakers on what the District of Excellence is and learn a bit of what has been going on there, and hopefully see what can be promising avenues for further research in the District of Excellence and further out. So I'll give the word to, I guess, Wilfred is standing, so he will be first.
Thank you, Johan. Am I audible? Super. Good. So, good morning, everyone. It's the last day and kind of sleepy, huh? Yeah, so as Johan kind of introduced us, it's a pleasure to present this kind of presentation and a journey which we kind of started 2.5 years ago, working with, of course, the University of Oslo, but also the local government in Tanzania, the Ministry of Health as well, to make sure that we create an infrastructure where we could actually be able to test innovations, workflow, and of course, learn from that and see how this learning can be scaled upward. So our presentation, as Johan said, we actually had a couple of abstracts submitted, and we thought that we could actually push this seamlessly so that we can see what we've been doing within the DOA structure. So we'll start with the profile, at least the team, to see who we are, at least, and also kind of explain the concept of DOA, because we think DOA is not only kind of an environment where we can work, but also invite other stakeholders as well to work. And we kind of put in place some how we see this DOA infrastructure works. We'll talk about what we are focusing right now and the context, the interventions which we have done on the last 2.5 years. And then, of course, we'll zoom in a little bit about 2 interventions which we think were quite relevant. And my colleague, Marina, will talk a little bit about that. And we'll give you a little bit of a use case and see how these interventions help the use of information at the local level. And then, of course, our colleague, Mahundi, who will be online, will kind of wrap it up, kind of what we have learned so far, what we're recommending, and what we are looking at as a way forward. So this is the team for DOE. In Tanzania, we have a couple of people with a different background. Mustafa Ngwila, Programmatic Officer. Masoud Mahundi is our Research Coordinator. Marina, who will be presenting also, is implementer, but also researcher. We have also our admin, project admin, but also an M&E specialist, Clement Kinga. We also have Fatma, who's kind of implementer, but also researcher, but kind of took the idea from Tanzania mainland and scaled it to Zanzibar. And of course, myself. So what is the DOE concept? So this is what we kind of think the DOE concept is, as an environment where people, different stakeholders can come with an idea and say that we want to test this thing, but we don't have an environment to test. And of course, we know when you're testing, you will fail at some point, but you learn through that particular failing. And of course, you'll be successful so that you could actually learn from that. So we think that as a DOE, this is something which different stakeholders can come with ideas, either technological, but also approaches in terms of enhancing the health management information system. And this is kind of the processes which we think they kind of are involved within the DOE concept. They are not, I mean, the image shows it's a little bit linear, but there are kind of half cycle, half baked cycle, and full cycles in terms of what you learn in the one stage could also inform the following stage, but also the previous stage as well. So on the introduction stage, this is where now the stakeholder come with an idea. We could actually look at it, see how the idea is, as I said, both technological innovation or innovative workflow. We can screen it, see how it fits the objective within the particular context. And then, of course, we need to sit down, not necessarily with the stakeholder, but also with the local government, with the Ministry of Health, or the ministry which that particular idea belongs to, and see how it could actually align with the existing workflow, existing information system, so that we don't create some parallel innovations or parallel interventions. And of course, after that, we kind of create a structured implementation plan. Following that, there is always an implementation. We think, based on our experience, training, capacity building is quite critical. You really need to kind of build the capacity and ensure that the people on the ground understand the innovation, buy the innovation. Of course, you need to monitor this progress. And of course, one thing which I've always learned is that we need to really engage the local team so that they can own the innovation. If you really want your innovation to scale well, you need to ownership of that and engage them since the beginning of the process. Of course, feedback is always important, so we kind of think that we need to have a regular feedback involving the stakeholders who wanted to test the ideas, but also the users, so that we can have that processing, an engaging process as well. We need also to test the innovation if it's really performing vis-a-vis the objective which we kind of set forth. And if it's not, then we need to tweak it, because this is kind of, as I said, it's kind of either half-baked cycle or full cycle. So we need to test, evaluate, test, and also learn from those mistakes or kind of best practices as well. Documentation is also important. And of course, the important part is disseminating. You really need to disseminate so that other stakeholders can understand what is happening, but also maybe jump in, engage more, and see how things are. And also, another thing is more or less whatever learning you have, you need also to kind of inject it back within that particular infrastructure. So this is how we are thinking and envisioning the DOE concept, and we kind of worked hard within Tanzania with the Ministry of Health, but also the Ministry of Local Government, to make sure that we set up that infrastructure where different stakeholders can come in and test some of the ideas and innovations. So the context, we started in Dodoma. Dodoma region. Dodoma is kind of our capital city, and there are two district councils were selected, Bahi District Council and Dodoma City Council. Later on, as I said, it was scaled to Zanzibar as well. Our colleague Fatma kind of took the idea and said that we need to also replicate this in Zanzibar. And there it went for two districts as well, Magharibi B and Kusini. The idea was this. We are selecting two districts to give a little bit of different context, one being urban, the other one being rural settings. And of course, as idea is more or less within these particular settings, you test some ideas, see how it works. One, in terms of how the idea is kind of take into by the users, but also how you can scale it across. So through the DOE concept or DOE project, we kind of came up with 4 thematic areas, kind of focus areas to kind of sharpen our thinking in terms of what are the innovation or what are the practices which we want to kind of focus on. And the first one is the data management information use in terms of coming up with innovation, coming up with the workflows to kind of cultivate and promote routine data analysis and information use, and specifically at the subnational level. Also, the second point, the second thematic area focusing on is the digital innovation, where we really kind of try to test the digital innovation within the subnational level and see how they are adopted and see how it can be scaled. Capacity building, that was also our third thematic area in terms of what are the best approaches in terms of building capacity and how can these approaches be scaled, because we know that it's quite expensive building capacity. However, if you come up with a better way of building this capacity, both formally and informally, or sustainable way of building this capacity, then it makes sense to kind of document this and also share. Research and documentation. We have been engaging researchers and postgraduate students, both are from local university, but also international. I think Johan touched base a little bit in terms of coming together. They come with their study areas, or sometimes we provide them with their study areas in terms of what we want to research. And then, of course, we conduct research together, document, and then, of course, disseminate. So what are kind of interventions which we have done? And this is kind of a very high level. My colleague will zoom into 2 interventions which we kind of done. And of course, we are structuring these interventions on those 4 thematic areas. So I think the first one which we kind of did was on data management information use, is that we saw that at the district level, still people at the facility are reporting for the sake of reporting. They are not really using this information. And when they want to use this information, either they meet up quarterly with all the health facilities and the district people to kind of go through the data. They are not really close to the data in a sense that they cannot make this decision whenever they need to. So what we decided to do was more or less scale down the reporting and analysis at the facility level in these 2 particular districts which we are reporting. So when we started, very few districts were, very few health facilities were actively reporting and use this information. However, by December 2024, we managed at least for all public health facilities in both district council were actively reporting and analyzing the data at the health facility. And we didn't even needed to kind of buy computers or tablets. I mean, they already have different projects we are running, which actually had already these devices. So we kind of kick back on this particular project and empower them to see that this is what we need to do. So I think that is number one. Number two, what we did it also is more or less kind of relying on existing practices, data use, data analysis, and use practices. And what we found that was these quarterly review meetings were quite important. However, either they were done ad hoc or they were not done at all. So what we did was more or less facilitating this quarterly review meeting and put a structured way in terms of what needs to be done prior to this quarterly review meeting, what needs to be done during this quarterly review meeting, and what needs to be done post this quarterly review meeting, so that you could actually follow up with these particular interventions. And another thing which we did on data management information use was more or less kind of streamline indicators. Within the National Health Management Information System, we actually had, I mean, you all know that within the DHIS2, you might have like 1,000 indicators. And most of these indicators, the national level are the ones who knows that. But at the facility, they might not even know the definition. So we kind of try to kind of come up with a simple set of indicators which will kind of address their needs there at the health facility. My colleague will talk a little bit more about these interventions and how we manage to do that. So these are kind of just pictures when we were participating in the data review meeting. This is one in Zanzibar, where we were able to go into the council, talk to the people, but also sit together with the facility and the district council and also the Ministry of Health at the national level to discuss the data and see some of these interventions. And this is also another data review meeting, which we're conducting in Dodoma, which we actually had to kind of introduce some of the innovations as well and see how they are using it in these particular review meetings. So on the second thematic area, digital innovation, we came up with a facility dashboard. Once we kind of had harmonized the indicators, then we moved now to develop this facility dashboard specifically for health facility so that they could actually, one, understand their performance, but two, also compare with their colleagues and see how their performance is. These kind of dashboard were quite relevant for them, and they were kind of using it now within their health facility, but also during the quality review meetings. We also introduced digital, other digital solutions, such as for here it was a chatbot where a master's student worked with us to kind of introduce the chatbot to assist users in navigating DHIS2 features and resources. So we build that capacity within the district and a facility as well, and see how they can use them. So this is kind of an examples of innovations which we did. Of course, there are so many others. For example, scorecard and etc., which we kind of introduce within the council. On the capacity building, capacity development, we kind of try different approaches, and each approach had its own strength and weakness. But I think what we kind of learn is that, instead of only focusing on physical, maybe also need to combine this with this mentorship and supervision, supportive supervision, where our colleague, our programmatic officer, was going actually to the health facility, sit down with the person, understand their problem, and also try to address this problem there using, within the work environment, but also using the real data instead of this training where you are coming together, and of course they're a little bit expensive. So what we were trying to do was, one, if you have a problem, they reach out to us, and this programmatic officer goes there. But sometimes we also have a structured kind of routine where our colleague kind of selects a facility based on the data which we have within the system, and then conduct this mentorship. What we have learned through this particular process is that as we do that, we saw that there are some health facilities. There were champions who were created through these particular processes, and these champions were able to themselves kind of coordinate and help themselves there. We also, of course, did an in-class training where we bring together participants in one class, work together with them and share. For example, in 2024, we managed to train at least 33 data managers coming from the council levels, district council, and 90 healthcare workers from the health facility, one, to be able to report and analyze their data, but also to use this information. So these are just an examples of the training sessions which we had, kind of building that capacity at the facility level to analyze data. And of course, giving them exercise whenever they come so that they could really kind of, or maybe use case, so that they can really use the knowledge which they have into a specific particular use case. And then, of course, on the research and documentation, we of course have done a number of studies looking in terms of what works, what doesn't work, and why does it work. As I said, we've been engaging some researchers, postgraduate students from the local international universities, UDSM, University of Oslo. They come with their studies. Some of them come with their studies. Some of them take some of the studies which we kind of put together, and of course we conduct these studies together. We've also been documenting and disseminating some of the lessons and findings. Our colleague has been participating in different kind of avenues. For example, we have this Annual Tanzania Health Summit, which we kind of presented our studies. We have also presented this study in WHO Health Assembly. We've also been using a media to kind of really promote the presence of the work which we are doing. These are kind of a summary of the list of research studies which we are going. As you can see, there are a couple of master's studies. Some of them are complete. There are a couple of other master's studies which are ongoing. We are happy, actually, 3 of the students who came in Tanzania last year with Johan and the team, they actually graduated last week, if I'm not mistaken. Yes, so it was kind of happy to see more progress being done on the research area. We also have PhD students working both here at the University of Oslo, but also in the University of Dar es Salaam, co-supervised by our team here, but also we have specific studies which our team within the DOE is kind of pushing forward on that. Yes. My colleague, Marina, will jump in now to talk a little bit about 2 of the innovations or 2 interventions which we have done within DOE infrastructure.
Hello. Good morning, everyone. Yeah, so I'm here to present it to you actually some of the intervention that we did in the DOE, but also findings that we came across with. So to start with, as Wilfred mentioned that before we intervene, we actually plan, and during the planning is where actually we understand what are the problems. And as far as action research, like the modality of HISP center is like the spirit of understanding the situation, solving the problem is very important. So upon assessing the context where the DOE project was conducted, we came across with the fact that DHIS2, despite the fact that it has been rolled out in the country for like many years ago, more than 10 years, but it's still struggling its potential to be realized by the healthcare workers, especially at the health facilities. So this part of the presentation is about the situation, what is happening, how the DHIS2 struggle and other digital solutions in the context of the healthcare facilities. So we all understand majority of our countries struggle with prior implementation of health information system, and that actually makes them to be for healthcare workers to have an even interaction with them. So because they have so many systems to work around, so at the end of the day, they just pick some, they concentrate with some based on some reasons. So at the end of the day, there's suboptimal use of system capability, including the DHIS2 itself, despite the fact that healthcare worker can use it to do analysis in a more convenient way, but they don't do. The reason behind, because maybe they don't have time, maybe they don't have enough support or skills, yeah, and so much more. So the motivation actually of assessing this concept, because we want actually to make the efficiency of this system, digital solution, to be highly realized, but also to save the investment, because we cannot keep on establishing system while they are not being used. So these are the motivation behind why actually we had to do this DOE project. So the main objective of this assessment was to examine actually the reality of users around parallel implementation of different competitive and comparative systems. So this was the methodology around. Actually, we picked some of the facility. We know, as Wilfred presented, the project cover Bahi district and Dodoma district. So there are so many facilities. So we picked facilities, making sure that they have well representation of all levels. Like we had dispensaries, we had health centers, and we had the hospitals. So upon assessing the facility, we actually interviewed some of the healthcare workers. We observed how they work around with these systems. So the observation was done during the field visit to the facility, as well as during the workshop that we conducted, and even during the training that we conducted. We also did system and document review to understand how this system actually empower and are being used by healthcare workers. So these were the findings. So with the fact that our target is to understand how health information system coexist and how users navigate or work around it, we found that these systems happen to be competitive to each other, and others happen to be complementing one another. But still, users fail to realize whether it's DHIS2 to complete paper-based system, but users at the end of the day, they keep relying on the paper-based system. Whether it's EMR, which is supposed to be complemented by DHIS2, or DHIS2 to be complemented by EMR, but that is not happening. So upon competitive challenges, we see that some systems are being established with similar functionalities. But at the end of the day, some systems are more stable than the other. So this is the reason why users may be abandoned or suspend some systems or even stop using them. So these are the realities that is happening. These are the realities that are happening at the user side when they find they have so many parallel systems competing with one another. Then we also have a complementary aspect of this multiple or parallelism of systems, whereby now the systems find themselves to have different distribution of knowledge across users. So you find DHIS2 being known, like few groups of people know how to use DHIS2, but other group of people know another system. But this system was supposed to complement one another. So due to this distribution of knowledge, at the end of the day, this system failed to complement one another. So this is among the reasons why the complementarity of systems are being challenged at this particular level. So what is happening? At the end of the day, we found some good practice whereby users now try at least to make sure that they get best out of this system. By having these working groups, like they coordinate themselves. So even if you are RSH NACE, working with the unit register, you know actually what you have collected. So for it to have good and quality data to be submitted to the DHIS2, which is being worked by another person, then they sit together and make sure that they have quality and good data. And this is also the same when it's come to use. Because the HMIS FOCO, who is working with DHIS2, does not know the context or the treatment aspect. So they need to work together to make sure that they complement one another. Whatever is collected in the paper-based tool by another person is complemented with the digital system DHIS2 that is worked by another person. So what need to be improved? So upon finding that, we thought like still our health information systems, in particular in Tanzania, need to strengthen the interoperability and integration aspect of system, but also operationalization of enterprise architecture framework, because it is there, but people don't follow it. So when investors, donors want to establish new system, they just start without considering what is already existing. Then the issue of policy enforcement, because in order now to make people follow the framework, you need to have policy which will enforce them. But you also need to harmonize our health information system investment, as well as contextualize our health information system establishment or implementation. Then last is to integrate and to have continuous capacity building. So as a DOE project, there are some things or recommendations that we have provided that we might not be in the position to do. But at least for the last two, to contextualize health information system, but also to have integrated and continuous capacity building was within our capacity. And those two drive us to come with the intervention which I'm going to talk it in part 2. Yeah, maybe a sip, sorry. Thank you. Yeah. So upon finding that DHIS2, with its beauty and potential to help healthcare worker, but it still struggle, then we say, okay, looks like health facility digitalization is still a challenge. We know higher level official, they might be enjoying DHIS2, but not to the same level with the healthcare workers. So we had different intervention to make sure health facilities digitalization is strengthened to a good level, at least to start with. So the reason behind, as I've mentioned, is slow adaptation of this digital solution, but also, and this is actually, it has been known for so long, even in the literature, like these systems are being considered as reporting tools, but that should not be the case. So, and some reason has been preached for so long, like healthcare workers consider digital solution as reporting tools because they don't have internet, they don't have computing device, they don't have skills, they don't have training. But that is not true in this particular era, because as you have heard from Wilfred, like facilities have computers, facilities have internet, but still data use or system use is still poor. So going deeply to investigate what is the reason behind, because these people have been trained on using DHIS2, they have computers, they have everything. So we assess the system, but also user practice, and these were the findings. We found like the configuration of DHIS2 is favoring more high-level officials. So you find that healthcare worker need like more skills to navigate around so as to accommodate or to get to whatever he or she needs. But also, there's issue of population data. As we all know, when we talk about routine or service data, we are talking about the coverage of some indicators like assessing or monitoring the performance of some indicators coverage like immunization, on NES, ANC part as well. So if you lack this population data within the system, the interpretation is you want this healthcare worker to do the coverage analysis outside the system and not inside the system. So if healthcare worker find like this is the trend, they ending up understanding, okay, this solution is not for us because what we need are not considered either, or have not been are not being provided by the platform. But also we found the issue of training. We have this culture of utilizing good training material from DHIS2, but those material are at high level, as you know. On the data end part, it is easy to show people, these are the data sets, these are the form that you need to integrate, and that it will be easy. But when it's come to analysis, we used to train our people like on the system features, like, okay, this is the data visualizer. This is how you navigate around data visualizer, but not going specific to the content. And this is a very big problem that we found in the field, because a person can locate the data visualizer, but now finding the content, where the indicator, what does it mean? That is a very big problem to these resource-constrained healthcare workers, because they need time now to navigate around, and they need like more indicator knowledge and understanding. So things are more on the high-level perspective. Understand that everyone is aware of everything in the system, from the feature to the content, but that is not the case. Then there's the issue of keeping pace with system content. For example, in our DHIS2 system in Tanzania, there are several revision being done time after time. So after some time, you find that we have so many indicators being revised, but people at the level of facility are completely unaware of what is new, what is old. There's the issue also of features. We'll talk to this later. So this is actually one of example, a few examples on how users at health facility struggle to understand the content of the system. This is a data visualizer screenshot. You see there I've pointed total OPD attendance, and there's another indicator, number of OPD attended. So this is just to show like this kind of naming can confuse the end user, but also can make the end user not to understand why the total OPD indicator is different from number of OPD attendance. So upon finding all these reasons why DHIS2 at the level of health facility is still being taken as a reporting tool, we had several interventions. So some have been mentioned by my colleague. Maybe I'll just go more deep into it. So first, we train user based on what they immediately need, and not the obvious training. So knowing we have limited resource, we have limited limited amount of time to conduct this training. Like you have only 2 days, 3 days, up to a week, and you need to train people. So instead of trying to teach everything that is within the system, we say no. We'll teach. For the data entry part was easy. We taught them the data entry and they mastered, but on the analysis, we picked those use cases, the reports that we found in the facility that they need in a routine basis, also the indicator that they monitor in a routine basis. So those were the key aspects for training them. And this was very successfully, because they were trained with less few things, but things that they real that they really need. Then we even generate context-based training material, because during those trainings we used to invite 1 to 2 people from the healthcare, from the health facility. So in order to make sure that whatever we train them will be cascaded to other colleagues, then we generate this context-based material showing them, when you go back, train your colleague on this and this and this. So we are not too ambitious to make them understand everything about DHIS2, but we were ambitious to make sure that they know how to use DHIS2 to fit their needs. Then we configured the facility-based dashboard, as we've had mentioned. So on the aspect of having this high-level official creating dashboard in the DHIS2 without consideration of how they are going to be useful to the frontline workers, we had this specific dashboard which capture indicator that facilities monitor in routine basis. So this was very helpful for them when they sit for data review meetings, when they sit for the monthly or quarterly data review meeting, then they could always refer, and it is easier for them because they have been given like access, which once they log into the system, they will just form the analysis based on their facility. They don't need to struggle to point where the facility is to navigate, because I think for us, high-skilled users, it is easy. But I'm telling you, for healthcare worker, to navigate the org unit component is not as easy as you can imagine. So we even thought like the org unit component could, on the analysis part, could even target like end user facility instead of keeping it where it's supposed to be alphabetically, because they struggle to navigate to get it. So we also developed population data, and since we have we have given access with the ministry. We were able to insert this population data in the DHIS2 because our current DHIS2 does not have population data for facility. So we entered population data for those facilities in Bahi and Dodoma and tried to ask them to navigate around this coverage indicator in the DHIS2 instead of doing manual calculation as they are doing at the moment by other facilities. Then we have this chatbot. So the reason or the idea of chatbot is to have continuous capacity building, as it has been mentioned from day one, that we can't have resources to keep on training users every time when we upgrade system or when we upgrade system features. So we need a means to make sure we maintain the capacity. And technology like AI is one of the promising solutions because through the chatbots, used at the facility, once the system is being updated and there is struggle maybe to navigate where this thing is now, it can just ask the bot how to create how to do analysis in data visualizer. Then the chatbot actually starts to instruct from the start where to get it from the main menu up to the last point. Yeah. So we have, so after all this intervention, we have some practical results, which we call them like success stories, because this year, February, we had an evaluation whereby we found like there are some improvements in the field. The planning process used to depend on the manual aggregation of data, but now they can be able to generate annual the planning report in the DHIS2, but even to obtain this is one of the reports that majority of the facility are required to have it in a monthly basis, and they used to keep it. They used to do it by doing manually, just coming with the table, and that's it. But after this knowledge, we found facility now they can even print the top 10 disease in different visual presentation. Then enhancement of data use during the data review meeting, etc. But also the outreach activity. We understand they use data to plan outreach. Before, it looks like this is just like a routine or casual thing that they do. But we had a very good story from Bahi Health Center, whereby one of their outreach activities was well informed by data. So what happened? After seeing a certain trend in the DHIS2 that there's an increase of women, pregnant women with anemia, they say, okay, we have to understand what's the reason, where these women come from. So as you can see now, DHIS2 has pointed the trend, the increased trend, but cannot tell actually where these women are coming from. So this is where they had to go back to the paper-based tools and the unit register and try to locate where majority of these women with high level of with anemia were coming from. So you understand now this is a complementary part of health information system. We cannot say we are going paperless, or even if we go paperless, we should also consider what was the importance of paper-based system before we just consider our higher level needs, etc. So they go back to the unit register and they were able to locate where these women came from, and they understand like that particular village, there is no dispensary. They used to depend on the outreach activity. And the way they were doing their outreach, they were just going as usual without folic acid, without people to take or to test their blood, their urine. So the next outreach, they were full compacted themselves with like what this particular village needs. Yeah, so my colleague is online to finish the last part.
Hello, greetings everyone.
Greetings, Maudu. I hope you can hear us. Please continue.
Yes, I can, Dr. Sanyani. So thank you very much. I also like to thank my predecessors in their presenting the DOE concept and the way we did implement it. So I am here to also present a continuation of it, which is related to findings and lessons learned. We also realize that some of the things which I will be presenting here have already been explained in a way or another by my previous colleagues. However, I will try and do it in a slightly unique way, as you could see from the slides. So, of the key findings that we found out is that half the challenges are non-technological, half the challenges that are to be addressed in the districts of excellence and in general the context of our countries are non-technological, even though when we say the DOE project is meant to help with innovations, but in reality, helping with these innovations is more than technological challenges. For example, there were a case where in the same DOE where we had them two hard tools, in this case the HMIS paper tools, with the data to be entered into the DHIS2, alongside which we have a number of facilities which have electronic EMRs. So you'd find an EMR existing in a facility, but still we have the HMIS tools also existing in the facility. So we realize this is not much of a technological challenge, but rather an organizational challenge, in the sense that one particular directive from high up would come and say, okay, now the DHIS2 to pick data from the EMR, and then the application of work to the health facilities would quickly be done. So yes, it's more than technological challenges. But we also realize that it is important that interventions involve users from the design stage. Interventions involve users from the design stage. You don't get into the DOE with your A to Z, the beginning of it, an end-to-end understanding of how an intervention is going to manifest. You need to also incorporate this design aspect. You need to also involve users. There were situations where we thought that we understood the context or other use cases of the data, but then we realized that there are different requirements in different contexts. In the DOE, for example, people at the districts, they are also expected to share data in specific meetings. One of the meetings is called the Ward Development Council. Another meeting is called the Primary Healthcare Meeting. But these meetings are different and they have different sets of data. So if one is to manage an intervention in the District of Excellence, it is important to first understand the different contextual requirements. That's why we think it's important that interventions are designed in the presence, or rather in the participation of users themselves. We also realized that one-off trainings are also not enough. You don't want to have a particular digital innovation and then convene people in one hall and then train them and then go away thinking that you have already institutionalized the changes in that particular place. So we think the trainings are not enough, as you will see later, and also as you might have heard from my colleagues who presented earlier, that we had some situations where you train a person and yet you come in the next time, you find them unable to do the same thing. We have one facility, I think it was in Pamantua, where they were oriented on how to develop the top 10 list of diseases, to develop a visual and then to print out. First, they were trained once and then somebody left. We came in for supervision with even colleagues from the University of Oslo. They didn't even know where to start. It's because training was not enough. There was supposed to be follow-up sessions, mentorship, and other ongoing orientations. So that's also one of the lessons that we have learned. Once-off trainings in a big auditorium does not suffice to institutionalize an innovation in a particular facility or a district. Another thing, we thought it's also very important to appreciate existing structures and institutions, to appreciate existing structures and institutions. Some of the things are very good to be there in health facilities. Some of the things are very good to be there in the districts. But if they are not part and parcel of the existing structures, it is very hard for them to be assimilated easily in the health facilities or in the districts. If an innovation is not supported by the management, if an innovation is not supported by the existing guidelines and structures, then it's not easy for that innovation to prosper or to progress in any how. So it is important to start by appreciating what exists in terms of structures and institutions, and then you understand where therefore to tap, what resources to tap, what sometimes not only resources, but also energy, the carrot and stick, where are the guidelines enforcing this thing, and then you would want to also plug in the innovation to sort of enjoy the wave of the support that exists in that particular place. Another thing that we also realized is that institutionalization and change is slow, and it has many dependencies. It is slow and has many dependencies, and it is therefore important to appreciate this. It's very important to appreciate this. You don't want to go there with the mindset that you're going to change things in a day or two or not even a month. Things have to be slow, and therefore, even in your planning of the interventions, this has to also be taken into consideration. I'm also mindful of the time, so if Wilfred would go next.
Yes, Monday.
Hello?
Yes,
If
we are.
you'd go next, please. Oh, okay. Yeah. Yes, so of the recommendations, we thought that instead of just orienting people on tools and the different elements on data use, the focus should also be on the institutionalization of the practices. Not only to go there and orient people on the visualization or the formerly pivot tables and others, but the mindset or the aim should be on the institutionalization. And if we have this mindset, it is therefore easy for us to sit back and observe what are the contextual requirements, what are the existing guidelines, what are the existing structures, the people managing the structures, and then the institutionalization of data use now can be easy instead of just going there and train people on a certain functionality or software capability and expect that data use practices will continue after you leave. So we thought the focus should be on the institutionalization. And on the second blob, I think it's like a follow-up of the first. Therefore, the institutionalization should also be accompanied by these continuous training. As we said earlier, one-off trainings do not serve the purpose of institutionalization. So you need to have these trainings, you need to have follow-up. And in our case, we even coined this in the mentorship. There are some practices we call the mentorship practices, and you'd find our manager there, the DOE manager, has a list of facilities and a schedule to visit them and to spend time with them so that they can understand it, internalize, but also assimilate them in their day-to-day practices as they manage their facilities and the districts. Another blob is about interoperability. There is a realization that the DHIS2, as we know that the DHIS2 in Tanzania now is a national standard. A few days earlier, we were commending ourselves that it was one of the, I think, the only software mentioned in the national budget that it has to be used, and all other systems have to be connected to this DHIS2. So we thought one of the things that need to happen from the level of the District of Excellence is that of facilitating interoperability between the DHIS2 and other dependent systems. Currently, there is this very high rise of the EMRs in different health facilities, and we think this is the area that we might want to start by tapping it. As they come, we have the mechanisms of connecting them to the DHIS2, so people can enjoy the available features which will facilitate their data analysis and use. But also leadership and leadership engagement to drive systems uptake. In most cases, if you focus in the lower level stuff and then you don't involve the high level stuff, today you orient them on this, and then tomorrow their boss comes and they are giving the different directive, then you're not likely to progress in the mission that you set forth to achieve. So it's important that you engage leaders, relevant leaders, so that they also buy in the interventions before you start that particular intervention. Well, sometimes it could be a chicken and egg where you want to first produce some sort of a of a test case for them to understand how useful it is. But all in all, it's important that the leadership is close by and it is with you as you are championing a particular interventions or innovation in their places of work. Another thing is sustainability requires institutionalization and budget commitment. As we have said earlier, you need to involve leadership. You need to also understand and appreciate the slow speed with which institutionalization change takes place. We also say training is not enough. You need to have this series of mentorship and follow-up and sustainability. So there is a need for exactly if you're planning things like this, if you budget things like this, if you're budgeting to institutionalize an innovation in certain place, if you're budgeting to institutionalize data use, data analysis and use practices, that you budget it comprehensively, taking aboard these challenges, including leadership buying in, understanding that things will be slow, understanding that you'll have several areas of following up, and so on and so forth, but also understanding that you would need a good capacity to document and analyze the different points of progresses so that the innovation can progress. So it is important that a budget and commitment is put in place. Looking ahead now is as in our understanding, as my colleague, the first presenter, showed, this is a framework. DOE is a framework in the sense that you have different sections. You have an element where we introduce innovations. There's an element where we plan all those interventions. And as the case is in Tanzania, we have done so much effort to work closely with the two ministries, the Ministry of Health, but also President's Office, local governments, and regional administrations. So we have set the ground. The infrastructure is now there, is maturing slowly, but it's now very much implementable. We think that it's an area that we can invite whoever think they have a particular intervention to test. Whoever has a particular practice, a change in practice to see if it works or not, then the infrastructure is there, but also the framework on how to do that is there. You'll have to meet the DOE management, which is inclusive of the HISP Tanzania University of Oslo, the regional administration and the ministries. Well, by names, it's complicated, but these are a few individuals which you will sit down and understand how your intervention can be tested and how the results can be extracted, documented, and shared. Yeah, I think that can summarize this looking ahead slide, given the time has also gone. So we thank you so much. Asante sana.
Thank you, Masood and Wilfred and Marina. Yes, we ran a bit over time. So I propose that you take the coffee break for questions, comments with Marina and Wilfred, and also remind you that all sessions should have a page on the COP, come into practice. So I encourage you also to post any questions or comments you may have there, so we can attend to them later. Yeah, okay, we'll allow one or two, but this is coffee, man. One or two.
Burning question which we can address. Only one.
Thank you so much, Wilfred T and team. Sorry, forgive my voice, it's a bit hoarse. I really love the idea of having this DOE as a research infrastructure. And in Uganda, where I'm from, we've attempted to do something similar on this. My question is, are you seeing any other innovations being set up or tested on this infrastructure for purposes of research beyond the interventions that you've already put in place? Thank you.
Can you hear me? Yes. So we spend a lot of the past 2 years to kind of set up this infrastructure. And doing that, we have managed to engage different stakeholders who were interested to start this up. We actually had engagement with our colleagues at some point with the USAID last year who were interested, but we all know what happened. So yeah, that's kind of a lost opportunity. But I think what we are trying to do right now is to continue to push forward, engage more stakeholders and come up and be able to test. What, for example, right now we're trying to do is also kind of looking ahead in terms of maybe test this climate and health interventions within this DOE infrastructure and see how it works and maybe more or less get more result out of that. Okay, we can always reach to us, our contact here, but me, Marina here, Mahond is online, but there are also other colleagues of us from HISP Tanzania. You can always reach out to them and yeah, engage in the conversation. Thank you very much. And